Very
Come
nice
dito,
place.
Tolong bikinin dari situ ya.
Foto.
Picture later.
Saya dari bawah apa dari atas aja? Dari bawah ya?
Yang ini belum bubar.
Oh my God! So we have confirmed cases in Manila already. So I'm not really sure whether the hospitals will go on lockdown.
Sisi deh.
Sorry. Tera makasih.
Apa asalnya kelihatan ya?
Pasalnya kelihatan.
Tera makasih. How many hours from Jakarta? 1 hour?
Dari Jakarta?
Yeah, you're
Bisa.
based in Jakarta Prof,
Yes.
right? Which hospital?
Actually, I have retired from the
So-
Nusa.
So you
I have retired.
so you're just enjoying life?
No, I haven't private practice
A private practice now.
because I'm 73 years old.
Doesn't look like 73, you're young.
So I
So
was
any
retired.
you're still some patient?
Oke.
Why not like enjoy your family, your grandchildren?
See how sorry.
But with the endoscopy, you see?
Yeah.
You see perform endoscopy?
Yes.
When is the right time to retire?
I did from 2 months ago.
Who does your endoscopy for junior? Junior. The fellow. Okay. So you're the mentor?
Yes.
You're the mentor of...
Rinaldi is my son-in-law.
Maybe we can stop now.
Rinaldi Cosmas?
Yes.
Okay.
Make a secret, yeah?
Cosmas. But your daughter is also a doctor. Other man.
Oh, we can stop.
We're going to start?
Yeah. We can have 5 minutes more. 5 minutes more because the
Other session.
other session is not yet finished.
So si Cosmas, how many kids?
2.
Two. So you're not planning to retire?
I'm
Cosmas
afraid
is
of
still doing the
asking.
endoscopy
Yes,
for you?
yeah. That my patient who
He
did
will-
the endoscopy or CT
So,
or the...
but you refer.
Yeah. Lasmana also like that.
Yeah.
She doesn't do the endoscopy.
Are we
5
going
menit. 5 menit ya.
5 minutes?
5 menit ya. Nah. Ya kan itu belum bubar juga. 5 menit ya. 5 menit ya. Gak apa-apa lah 5 menit.
I think it's done already.
Ya.
But I'm so happy that the convention is successful.
Ya.
And
Tidak.
then it's very well prepared.
Ya.
Because last year I was the one who prepared for Manila. I'm
What time is it?
last year
Last year.
I was the Secretary General for Apasal Manila.
Oh yeah, I'm not been there at that time.
So I'm happy that everything is okay, super preparation, everything
Thank you
checked.
so much.
And then it so happened that it's because of the COVID-19, but everything perfect.
Yes.
Arrangements.
So you enjoy it, right?
Yeah, and then I'm so proud.
Of course. Also, his wife will coming on Sunday. And then they get an
Go
5
1 week, 1
days
week.
one.
I'm happy, Professor, because despite what happened, there the convention continues and the sponsors support is good.
Yeah.
Every, except for the audience, except for the number, but everything is well prepared.
Oh, thank you. Last time I met Jose 6 months ago.
Yeah, where?
Here in Bali.
For another conference?
Yeah.
Ah, yeah,
Just
the
in
one
person.
with the, I think the black collar invitation.
Yep.
Indonesian something.
No, in Jakarta, not here. Jakarta.
Sí.
Okay, you can find. I buried the curriculum vitae for you.
Hmm?
I buried this one.
Yeah.
Invite the speaker. Itu lebih bagus baterainya.
Because I finished last year around 2000. I'm 47 now. Not yet. But Cosmos is good younger than me. It's really Cosmos is maybe early 40s. Younger.
Yeah.
He's younger than me. Good afternoon, ladies and gentlemen. Welcome to Symposium 20 on infection in hepatobiliary diseases. First and foremost, I'd like to congratulate Professor Rino Gani and the organizing committee of the APASL 2020 Bali for a very successful convention. So here with me today is my co-chair, Professor FX Pridadi, Indonesia. So we're going to have three lectures from our distinguished speakers. So each of the lecture will last around 20 to 25 minutes, and after the three lectures, we're going to have an open forum.
Thank you. For the first speakers, we invite Dr. Saud Horas Nababan. Dr. Saud Horas Nababan is from Medical Institution Cipto Mangunkusumo Hospital, Jakarta, and he is a consultant of gastroenterology on the same hospital. Please.
Thank you, Mr. Chairman. Good afternoon, dear colleague. First of all, I would like to say thank you to the APASL Organizing Committee for giving me the chance to be here. And the topic of my talk this afternoon is the tropical infections and liver toxicity. So I have no disclosures, and because due to the limited time, I would like to focus on the most common infections in the Asia-Pacific regions. They are dengue infections, malaria, and leptospirosis. So let me start with the dengue infection. So if you look at the distributions of dengue infections worldwide, it had been shown that dengue is the most rapidly spreading mosquito-borne viral disease in the world, and it has been reported that in the last 50 years, the incidence has increased 30-fold, with increasing geographic expansions to the new countries. And some 1.8 billions, which is more than 70% of the population at risk for dengue infections, are located in the Asia-Pacific regions, which is bear nearly 75% of the current global disease burden of the dengue. So if you look at the dengue infections, we know that dengue infections is caused by the infections by the dengue virus. There are 4 serotypes, 1, 2, 3, 4, transmitted by the mosquito of the genus Aedes, usually Aedes albopictus or Aedes aegypti. And so far what we know that the pathogenesis is very controversial. At least there are 2 hypotheses has been put forward. The first one is the antibody dependent mechanisms, and the second one is the virus virulence hypothesis. So in the antibody-dependent mechanism, as we can see on the left, that in the presence of the low affinity or the poorly neutralizing cross-reactive antibody against the dengue virus during the first infections, and this condition can promote entry of the dengue virus into the macrophage or Kupffer cells of the immune cells, and this can lead to the secretions of the vasoactive mediators, and also the formations of the immune complex will contribute to the complement activations, and both cytokines and cytokine secretions and the complement activations will contribute to the increase of vascular permeability, which can lead to the hypovolemia and shock. What is interesting about dengue virus that it shows specific tropisms. We know that dengue virus can directly invade the immune systems, the endothelial cells, but also the dengue virus can directly infect the hepatocytes or the liver. So if you look at the current case definitions by WHO, the dengue case is can be divided into with or without warning signs, and both can develop to severe dengue. So if the patients come with fever with 2 or more symptoms, such as nausea, vomiting, rash, myalgia, then we can consider dengue infection in our differential diagnosis. And if there is a warning sign, such as abdominal pain, persistent vomiting, mucosal bleed, lethargy, or hepatomegaly, then this could be a warning sign. And in a severe dengue, we should be look for the signs of severe plasma leakage, like shock or pleural effusion. Or from the liver perspective, we can see a high ALT AST more than 1,000. So if we look at this dengue case definitions, we can understand that if there is a liver involvement, it could indicate a severe dengue. So this is very important. And if we learn about the clinical phase of dengue infections, we know that there is an early fibril phase, the critical phase, which is usually occur from day 4, 5 to 7, and then recovery phase. In critical phase, usually the fever will go down, but there's evidence of the capillary leakage. So if you look from the studies that from dengue infections, the study showed that at least 2/3 of adult dengue patients have shown abnormal liver functions, and acute severe hepatitis with elevations of transaminase level of at least 10 times can occur in about 4 to 50% of adult dengue infections. But usually the majority of high ALT level usually reported among the children. And if we look again at the data that mostly patients with liver involvement come with abdominal pain, vomiting, and usually the hepatomegaly could also be present, and usually this is indicate severe dengue, usually found in dengue shock syndrome or dengue hemorrhagic fevers. On the other hand, the hyperbilirubinemia or jaundice is rarely seen in dengue infection. So if we see high bilirubin level in dengue infection, we should consider other differential diagnoses other than dengue infections. And if we look at the pattern and liver involvement in acute dengue infections, we can see that in severe disease, severe dengue infections, in day 5, 6, 7, there are high ALT level compared to patients showing no signs of severe disease. I think this is very important because we know that on day 5, 6, 7, this is the critical phase, and in this critical phase, we see a much higher ALT and AST. And if we look at another data from Thailand, which collect almost about 2,000 cases, and look at the incidence of acute liver failure. And in this study, they define the acute liver failure as the evidence of ENR more than 1.5. And we can see that in this study that the mean duration from fever to onset of acute liver failure is about 7 days. So this is a very important data that if you see the patients with a history of 7-day fever with acute liver failure, then we should consider that this is a severe dengue, especially if come with the high ALT. In this study, they also look at some risk factors for acute liver failure in dengue infections, and from the multivariate analysis, they show that younger age of patients with more than 10% atypical lymphocyte with platelet count less than 50,000 per meter cubic, and this is the risk factors of acute liver failure in dengue infections. And if you look at the pathogenesis of liver injury in dengue infections, it is very clear that the pathogenesis are very complex, but we can see there are two major contributions. One is the direct viral cytopathic effect of the dengue infections, and secondly is the immune-mediated injury. So following a mosquito bite, dengue virus will enter the bloodstream and reach the liver. And after entry to the hepatocyte, usually mediated by receptor-dependent independent mechanisms, what happens next is that the infected hepatocyte will express the interferon alpha, beta, rantes, and some interleukins such as interleukin 8, 6, 10, 12 through activations of NF-kappa B signaling pathway. And the secreted interferon alpha and beta will enhance resistance to viral infections in the neighboring cells, while other interleukins will attract NK cells, CD8 and CD4 lymphocyte. The CD8 cells will recognize the viral antigens on the hepatocyte and express the fast ligand and granzymes that induce hepatocyte apoptosis, while the NK cell will enhance the trail expressions and thereby induce apoptosis in the hepatocytes. Dengue viral infections could directly induce hepatocyte apoptosis by trail upregulations and also P53 dependent caspase-1 activations, and also through capsid protein mediating effect and endoplasmic stress. If we do the biopsy from dengue infected patients, usually when the liver involved, usually the histology show that there is a steatosis seen in the hepatic globules in almost all cases, with hepatocyte ballooning and also nucleated and fragmented cells dislodged from hepatic cord, which indicate that there is a cellular apoptosis going on in the liver. And usually the inflammation's degree is very mild. Usually there is a mild lobular and portal inflammations containing only a small numbers of lymphocyte, monocytes, and neutrophil, but usually we don't see any liver fibrosis. So in general, the treatment of dengue infection is supportive. We need to maintain the hydrations and tissue perfusions by fluid. And I think it is very important, if there is liver involvement in dengue infections, we should identify if the patients have underlying chronic liver disease, and we should also exclude the possibility of co-infections or other cause of liver injury such as. And some studies suggest that in the presence of comorbidities such as diabetes, usually increase the risk of liver failure. As for the pharmacology therapy, there are some case report or case study that report the use of N-acetylcysteine in the presence of acute liver failure due to dengue infections. And also there are some case report reporting the efficacy of artificial liver support systems such as molecular absorbent regulating systems when acute liver failure occur in dengue infections. But so far, there are no RCT that evaluate the efficacy of both of these treatment. So let's move on to the malaria infections. Malaria infection is caused by parasitic protozoan of genus Plasmodium, and in the Asia-Pacific regions, the majority is caused by Plasmodium falciparum and vivax. And when the human malaria infections initiated when a female anopheles mosquito inject the Plasmodium sporozoid into the skin during a blood meal, and when the sporozoid actively reach the peripheral circulations and migrate to the liver, in which they replicate within hepatocyte and form merozoid that are then released into the bloodstream. However, this hepatic stage, usually there is no sign of liver impairment. However, when merozoid invade the red blood cells and develop travozoid and schizon state before forming new merozoid, and they are released at the schizon egress and reinvade new RBC. Usually, when the merozoid release into the peripheral circulations, usually the sign and symptoms will occur. So if you look at the epidemiology in Asia Pacific, I think it's very interesting because malaria remains a major cause of death and illness, with estimated about 2.1 billion people in Asia Pacific region at risk of infections. It has been reported in 2015 that the total number of confirmed cases is about 2.5 million. And the endemic malaria transmission occur in almost all nations of the Asia Pacific regions, excepting only in Japan, Singapore, Australia, and New Zealand, and Sri Lanka has been reported recently arrested endemic transmissions. And we know that the Plasmodium falciparum and vivax is the two most dominant Plasmodium in the Asia Pacific regions, and if we look at the distributions, we can see that the distributions of Plasmodium vivax reach much farther north than the falciparum. And there are a couple of important reasons for this. Because the first one is this species develop quicker at lower temperature in a cold-blooded mosquito host, allowing it to thrive in a low temperature where Plasmodium falciparum cannot tolerate. And secondly, Plasmodium vivax is able to place dormant forms in the human liver, providing it a safe haven during the harsh winters. For example, in the Korean Peninsula, where there can be no mosquitoes to transmit them. And if we look at the liver injury pattern in malaria infections, we can see that there are different severity between Plasmodium falciparum malaria and vivax malaria. It is much higher bilirubin and ALT and ST levels significantly in the falciparum malaria and compared to the vivax malaria. I think this is very important data because if we found a much higher liver impairment, we can suggest that probably the infection caused by the falciparum malaria. Another definition has been put forward, even though there is still no general agreement in how defining the malarial hepatopathy. But at least there are some definitions that can be used. This slide shows some of the criteria. The first one is the increase in ALT more than 3 times, demonstrated at least in 2 consecutive blood levels. And also there's an increase in the bilirubin level more than 3 milligram per deciliter. Usually the conjugated bilirubin is much higher than the unconjugated. And also the absence of clinical or serological evidence of viral or drug-induced hepatitis. And usually there is a clinical response to anti-malarial drugs or evidence of disseminated malaria infections on autopsies. And the malaria hepatopathy has been reported around 2 to 60% and more common in falciparum malaria. What we should consider when we encounter patients with a high ALT level or high bilirubin level in patients with malaria is that there are so many differential diagnoses. We should consider the viral hepatitis, the bacterial infections such as leptospirosis, typhoid, and also beside Plasmodium malaria, we also should consider toxoplasmosis and others cause like obstructive jaundice, ascending cholangitis, and also drug-induced liver injury. And there are some parameters that can help us differentiate between the malaria hepatopathy, fulminant hepatic failure from viral fulminant hepatic failure. So in malaria hepatopathy, we usually see the hepatosplenomegaly, and the hemoglobin is very low, with low platelet, but the white blood cell count is normal, while in the viral, usually the white blood cell count is elevated. And also in malaria hepatopathy, usually we see impairment of renal function with increase in blood urine nitrogen and creatinine, while in viral fulminant hepatic failure, usually the creatinine is normal. And if you look at liver tissue from malaria patients without hyperbilirubinemia or hyperbilirubinemia, there are some evidence that there are sinusoidal congestions, there are minimal fatty changes with RBC sequestrations and dense portal inflammations with Kupffer cells with hemozoin pigment, also the signs of apoptosis Kupffer cells. In general, the treatment of severe malaria consists of ABC assessment and monitoring, and also the maintenance of hydrations and fluid balance. And when the seizure occur, benzodiazepine has become the first choice. And we have to be careful for other concomitant infections, and we should treat it accordingly. We should avoid aspirin or corticosteroid to prevent the GI bleeding, and we should monitor regularly patients with severe malaria. The first line treatment in severe malaria is the parenteral artesunate for minimum 24 hours, continued by oral artemisinin-based combination therapy for 3 days. Next, I would like to talk about leptospirosis. So leptospirosis is a widespread and potentially fatal zoonosis that is endemic in many tropical region in Asia Pacific region due to the heavy rainfall, flooding, and also the current climate changes. And infection usually result from direct or indirect exposure to the infected reservoir of host animals that carry their pathogens in the renal tubules and shed the pathogenic leptospira in the urines. And there are many wild and domestic animals that can serve as a reservoir, but usually rats is the most important source of human infections. So if we look at the data in Asia Pacific regions, we know that there are some difference. Leptospirosis has been high in several countries like Bangladesh, Cambodia, Fiji, India, while it is moderate in parts of China, India, Indonesia, and Malaysia, and is very low in countries like Australia, Hong Kong, Japan, South Korea, and Taiwan. And we look at the clinical features of leptospirosis. So after 2 to 20 days incubations, the onset usually abrupt with fever, headache, myalgia, and it's like a flu-like syndromes. And we can see that there are some classical sign. There's a classical how we can identify the leptospirosis. There is the conjunctival sufficiency, where there are dilatations of the conjunctival vessel without prolonged exudates, which is occur frequently in leptospirosis, but very uncommon in other infectious diseases. And other ocular findings include the subconjunctival hemorrhage and then also the icterus. The diagnosis of leptospirosis can be accomplished by detections of the organisms or its component in the blood tissue or in the body fluid or tissue using PCR or culture, or by detections of specific antibodies or serology. And Anti-leptospira IgM antibody are detectable early in the course of disease, so approximately at day 5. So the clinical manifestations of leptospira can be divided into two. The first one, the anectatic phase and the icterohemorrhagic phase. In the acute phase, patients come with the flu-like syndromes, while in the ectohemorrhagic phase, usually we found many complications like renal disorder, hepatic disorder, widespread hemorrhagic. There are some pulmonary signs and cardiac signs. I think this is very important when we find leptospira patients with jaundice, with increased ALT level, then patients in the ectohemorrhagic phase, and usually these patients have severe disease. And if you look at the clinical presentations of leptospira, the most common presentations usually non-specific. The jaundice has been reported about 40% of cases, while the ocular findings such as conjunctival sulfations is in about 30%, and about 70 to 70% reported an increase in ALT and bilirubin levels. So the liver involvement in leptospira is a common finding in the leptospira infection. So if you look at the associations with leptospira severity and the serogroup, it is quite clear that in the leptospira infected by the serophile enterohemorrhagic strain, the jaundice and the increase in the bilirubin and ALT level usually is much higher compared to the non-ectohemorrhagic serophile. So if we look at the liver pathology in liver cirrhosis, we know that there is the histology usually show lack of normal adhesions between hepatocytes, and the hypothesis is that in the leptospira, the expressions of E-cadherin in the liver cell is diminished or absent, and thus contributing to the lack of stable intracellular adhesions. And this will cause the leptospira migrate to the sinusoid and biliary capillary, leads to bile leakage and the jaundice. So the treatment of leptospirosis has been parenteral high-dose penicillin or ceftriaxone. However, in the acute liver failure setting, there are only several case reports that report the use of artificial liver support systems. The use of MARS, plasma exchange, and hemodialysis show a promising strategy if we see patients with acute liver failures, but in case of plasma exchange or plasma apheresis, due to the possible immunosuppressions, it has been reported that this patient develop another infections such as CMV, infectious colitis CMV. If your institution doesn't have a mass of plasma exchange, then probably hemodialysis can be a good option, especially with renal involvement in the severe leptospirosis. So lastly, I would like to highlight one study in 2013 from India that looks at the etiology of acute and chronic liver failure. And from this study, they show that although the bacterial infection is the most common acute insult in acute and chronic liver failure, but they also reported 2 cases of falciparum malaria and 1 cases of dengue. So I think the message here is that if you find patients with acute liver failure, acute and chronic liver failure, we should also consider the possibility of infections of such as malaria and dengue and also leptospirosis. So to conclude my talk, in Asia-Pacific regions, dengue, malaria, and leptospirosis are still the major health problem. And the liver toxicity in this tropical disease can range from impaired liver function test to the fulminant liver failure. And if there are impairment of liver functions or fulminant liver failure in this tropical disease, it usually indicate a severe disease. And please consider tropical disease such as malaria, dengue, leptospira in your differential diagnosis of when you see patients with acute or chronic liver failure. So thank you for your attention.
Thank you. very much, Professor Nababan, for that insightful lecture. So let's move on to our next speaker. Our next speaker is Professor Joferdi Cunyawan from the Chipto Mangunkusumo General Hospital Department of Internal Medicine. So we'll talk on the updates in the management in pyogenic liver abscess.
Okay, thank you for the nice introduction, Mr. Chairman. I also would like to thanks for the organizing committee for invite me to the such wonderful events. Good afternoon, dear colleagues. Assalamualaikum warahmatullahi wabarakatuh. My topics in this afternoon is update management in pyogenic liver abscess. This is my outline. So for the introductions, even the incidence of the pyogenic liver abscess is not quite frequent, but pyogenic liver abscess is potentially a life-threatening disease. In developed country, maybe it's more few than the developing countries like India and Indonesia. Maybe also the different kind of the abscess. The developing countries may be more likely, more frequent, the amoebic liver abscess. This is a schematic from the liver abscess, and the infection route that maybe we should know that abscess can happen, or can occur in the liver also by the contagious spread, the hepatic artery, via bile ducts, and also by a portal vein. Now, the etiology of pyogenic liver abscess is most frequent by the biliary diseases. These are replacing the common cause like appendicitis, and if the caused by arteria hepatica, we should suspect about the using of immunosuppressant in the patients, or there are the history of chemoembolization of the arteria hepatica. So like maybe the SCC patient that have already have a taste, arterial chemoembolizations also have a risk for occur in pyogenic liver abscess. So it's very important to also look for this kind of complications. So in these case reports, this reporting about the many various of the etiology, like a portal vein sepsis, biliary tract sepsis, but we can see that the most reported cases is caused by the biliary tract sepsis. For the cause of the pyogenic liver abscess, mostly it's a negative gram microbacteria. So even there's E. coli or the Klebsiella pneumoniae. So also the risk factor of liver abscess that we should pay attention is about the patient that have had diabetes mellitus, liver cirrhosis, immunocompromised patients using of PPI, maybe long time using of PPI, advanced age, and male gender. And those risk factors also can contribute the increase for the mortality if they're happening also the multi-organ failure, sepsis, and also the rupture of the hepatic abscess, the size of larger abscess, more than 5 cm. Also there's a kind of respiratory distress, hypotension, jaundice, and also the extrahepatic involvement. So the clinical manifestation is a classic triad. There's a fever, pain of right upper quadrant abdomen, also malaise that we should know. And the most frequent symptom is a fever and right upper quadrant pain. Also, if the inflammation reaches the diaphragm, also the symptom can cause the shortness of breath, cough, and also prostatic pain. And the pain also will felt and spread to the upper shoulder. So if the abscess is happen or occur in like segment 8 in the liver, it maybe can cause the inflammations that reach the diaphragm. The physical examinations, yeah, we can find the right upper quadrant abdominal tenderness, jaundice, and also the hepatomegaly. So if the laboratory findings, the most findings is increasing of the white blood cell or leukocytosis. And the modalities for diagnosis of pyogenic liver abscess, the culture, if we get the culture from blood, maybe only positive for 30 to 60%. If we do the culture from the aspirate, maybe we can found the organism or positive culture for 70 to 80%. Using USG ultrasound and the CT scan have a comparability sensitivity. It means it can comparable. I think we can diagnose liver abscess. I think using ultrasound is quite sufficient enough to get the diagnosis of liver abscess. I think it's not necessary to get to do the CT scan because the sensitivity is quite high. Of course, in ultrasound is very operator dependent, so it means we should increasing our skill in liver ultrasound. This is the common features of the ultrasound from the abscess. The common features, there's a hypoechoic, it means hypoechoic appearance with the internal echoes inside, and also there's a irregularity in the wall of the lesions. And also to make sure there's a fluid, that the hypoechoic part, that we should find the posterior acoustic enhancements below the lesions. So it is the typical appearance of the abscess from the ultrasound. From the CT scan, we also can see the multiple lesions, small with the straight lines and the minimal edge of forming. So if we're using a contrast CT scan, we only see the edema in the peripheral lesions with the irregular borderlines. Okay, and also if they have still a solid part in the middle or in the edge, we also can see a double target sign, hypoechoic lesions, and some of the hypoechoic lesions with still a typical appearance in the edge around the lesion with we have edema. So if the contrast ultrasound, we will have an enhancement in the peripheral of the lesions. Okay, and also have a gas. If a gas is suspected in the lesions with the abscess, is most likely is a pyogenic abscess. In this figure, we can see there's a metallic stand that already deployed for the obstructions in the biliary tract. And also we should know that the clue that cholestasis conditions or the icterus obstructions, it most likely maybe the abscess is pyogenic, because we all know that the bile itself is very little for the amoeba. So in the cholestasis or the icterus obstruction, if there occur the abscess, is most likely is the pyogenic abscess, like in this this kind of figures. So sometimes you also can differentiate between the Klebsiella pneumoniae and non-Klebsiella pneumoniae for the pyogenic abscess. Klebsiella pneumoniae, they can have a typical figure of the CT scan. They have a thin septae with some of the still semi-solid part of the abscess, maybe like mimicking like a honeycomb appearance. But if the non-Klebsiella pneumoniae, we can see the thicker septae with the more liquid part in the abscess. Okay. What about the management in pyogenic liver abscess? There's a multimodal therapy, like broad spectrum antibiotics, percutaneous needle aspirations, percutaneous drainage, and surgical interventions. In this algorithm, we can see that if the hepatic abscess is ruptured, is no place for percutaneous interventions. Okay, so if the ruptures is a surgical drainage or resection is the options. If iatrogenic, even is not ruptured, also the first option is recommended to do the surgical interventions. But if not iatrogenic, if not ruptures, if less than 3 cm, we can start the initial treatment with antibiotic therapy. If there's no improvement, 3 or to 5 days maybe, we can do the percutaneous drainage. But if the size of diameter is 3 to 5 cm, if uniloculated, we can initiate directly to percutaneous drainage. And if unsuccessful, we can continue the second percutaneous drainage. If that is successful, yes, we can move on to surgical drainage. In the multiloculated, the first choice is surgical drainage. But there's others algorithm recommended by SINGS. If the amoebic serology is negative, so first we start the broad spectrum antibiotics. If the diameter is less than 5 cm, is recommended to do the aspirations, and more than 5 cm, we do the percutaneous catheter drainage. Of course, the thing that we don't have to satisfy to do the drainage or the aspiration, we should also look the etiology of the abscess. So please look for the etiology, like if there's obstructions, please do the drainage for the biliary obstructions like RCP or PTBD. Look also the diverticulitis that maybe we can overlook. So maybe if the patient, our patient is have a repeat abscess happen, maybe the source of infection we don't overcome, like the diverticulitis and also the chronic appendicitis. So please do the drainage and also look for the etiology, what caused the abscess, the pyogenic abscess. Okay, so the antibiotic pyogenic abscess is fatal mainly to the sepsis and peritoneal secondary to the ruptures. And main therapy we using the broad spectrum antibiotics, and the product antibiotics is recommended to be given intravenously until 3 weeks, and then followed by oral administration for 2 to 4 weeks. And giving antibiotic alone is not effective if the abscess is giving antibiotic alone is only effective if the abscess is the diameter is less than 3 cm. So more than 3 cm, it's not sufficient to give antibiotics alone. We should do the drainage. The empiric antibiotic regimen's choice, we can do the monotherapy, like giving the piperacillin tazobactam or ticaracillin clavulanate. If we want to give the cephalosporin, please do combination with the metronidazole. Or we want to give the fluoroquinolone, please also give combination with the metronidazole. Percutaneous drainage is a patient with the following criteria that have been suggested. Yeah, the patients that not that there is not any improvement after 2 or 3 days after we give adequate antibiotics and the aspirations. So we should move to the drainage, percutaneous drainage. It means we can put the catheter drainage to the abscess. And the liver abscess is more than 5 cm. And also there's a clinical features that impending perforations. So we should give the continuous drainage. And it should be helped by ultrasound gaudet, of course. And percutaneous drainage is widely used during the past 3 decades because it's simple and avoidance of general anesthesia and laparotomy. And you et al. Found that the intermittent needle aspirations was probably as effective as continuous catheter drainage. So if we can have the catheter drainage, also if we can do the multiple percutaneous aspirations if we don't have any sets of the catheter to do the catheter drainage. So the effective of percutaneous drainage is the same with circular drainage in multiple vaginal abscess. And percutaneous drainage should be performed before surgery because it's lower morbidity and cheaper. But surgery is also an option if the percutaneous therapy is failed. So surgery is the last options, I think, in the liver abscess because I think is other centers also. Our surgeon, the executive surgeon, is not really frequent doing the aspiration for or the open operation for liver abscess nowadays. Okay, to see the differentiate between the aspiration and catheter drainage, we see because the aspiration only stick it to the needle to the abscess and then we aspirate, but using the catheter, we put the catheter and let it flow, and maybe we do aspirate 2-3 times a day. Yeah. Okay, using drainage by guided ultrasound, we can using the SIBA needle to do the aspirations, and we can aspirate the abscess manually or also with the vacuum machine. Okay. Yes, this is the example of the amoebic liver abscess. Okay, if the abscess is pyogenic, we can see there's a brownish aspiration, sometimes yellowish abscess is the typical appearance. I think the battery is charger, please. The computer is shut down because the battery is low. Udah colok datanya. Laptopnya mati ya. Ini udah bisa nih. Udah nyala, duduk sini aja nih. Sini aja, sini. Sini aja. Okay, the computer is in front, is already on. Maybe you can help me to because it need a password here. Okay. Sudah. Okay, so I move on. So if we should abscess like this, the anchovy paste, this typical appearance of the amoebic liver abscess. Like this, we put the catheter drainage. And for general considerations, ultrasonography is standard modality for diagnosis, also a therapeutic drainage for abscess, and image-guided drainage is the best modality for treatment of liver abscess. In case of larger abscess, more than 5 cm, ultrasound-guided percutaneous pigtail catheter drainage is superior therapeutic approach than the percutaneous needle aspirations. If there are multiple abscess, you have the bigger one and the smaller one, it's recommended to do the percutaneous drainage in the larger ones and then aspirate the smaller ones. How about the larger abscess? There's a report using the percutaneous drainage catheter. The patient liver abscess more than 10 cm is not a contraindication to do the percutaneous drainage. So it's still effective, especially for the patients that have the very old, elderly patients, and also reluctant to do the open drainage is also option to do the percutaneous drainage. So the open drainage only indication if there is no clinical response within 4 to 7 days after drainage using catheter, maybe multiple and large abscesses, and there's a thick wall with the thick pus. Sometimes we do the multiple aspirations and also we put the percutaneous catheter. Sometimes also we can drainage. Some of the reasons because the thick pus, also we do the spool with the water. Also we can make the pus thinner. So it's the one of the indication we should do the open drainage. For our conclusions, antimicrobial therapy and percutaneous interventions form the mainstay of the treatment. Surgical intervention should be considered for patients only with large, complex, septated, or multiple abscesses, underlying disease, or in whom percutaneous drainage has failed. Thank you very much.
Thank you, Professor Corneowan. Maybe, Professor, you can introduce the next speaker.
For the invite Professor Nechati or Mechi, he is a professor from the President of Turkish Society in Gastroenterology, member of the Turkish Gastroenterology Association. The topic today is biliary sepsis management, percutaneous, endoscopic, or surgical. Please, Dr.
Mr. Chairman, ladies and gentlemen, first of all, I would like to thank the organizing committee, Dr. Gani, Dr. Lesmana, and the others for giving me opportunity to talk in this very important meeting. So my topic today is the management of biliary sepsis by percutaneous way, endoscopic way, or surgical way. Biliary sepsis or biliary infection, especially in acute cholangitis, is very important disease, very dangerous disease. Why? Because this disease makes sudden deterioration in the conditions of the patients, and the mortality rate quickly will up to at least 10%, sometimes until 40%. So when we suspect the biliary infection or acute cholangitis, as soon as possible, we should try to treat the patients, at least antibiotics. And then we have to measure of vital signs of the patients, such as blood pressure, heartbeat, respiration, urine output, and also fever, also consciousness. If we judge this is moderate or severe cholangitis, then, as I mentioned, as soon as possible, we have to begin to treat the patients. we have to assess the severity grading and also general status of the patients. If that clinic able to drain the patients, then no problem. But if they don't, then the patient should be transferred to another ability center. There are several causes of cholangitis, especially mostly biliary stones, benign or malignant strictures, sometimes non-surgical biliary interventions, such as ERCP, or percutaneous transhepatic cholangiography, or biliary stents, and sometimes, of course, parasitic infestation, such as fasciola hepatica or ascariasis, make acute cholangitis. For the diagnostic criteria, first, we have to check systemic inflammation. Fever or shaking chills, or laboratory data such as, let me grow up this one. Can you help me please make it bit bigger because it's difficult to read. Can somebody help me, please? No. I want to make it bigger. The whole, yes, whole screen in this computer. Can you make full screen?
Iya, ini maksudnya.
Thank you. So first we have to check systemic inflammation is there or not. Fever or shaking chills and the laboratory data about especially evidence of inflammatory responses. White blood cells should be higher than the 10,000 per milliliter. And the jaundice or abnormal liver function tests. So alkaline phosphatase or gamma GT or AST ALT should be higher than 1.5 fold. And then imaging, such as in the ultrasound examination, biliary dilatation, or sometimes we can see any kind of stance or any kind of malignant obstruction in the common bile duct or somewhere in the biliary system. And then evidence of etiology on imaging stricture, stone, and stents or something. Then for the diagnosis, at least we have to find at least 1 point A or 2 point B, or sometimes A plus B or plus C. If we can see these, any kind of options, then we can diagnose this is acute cholangitis. So Tokyo guidelines 2018 diagnostic criteria for acute cholecystitis. In this case, again, local signs of inflammation. For example, Murphy signs, that means when the patient had a respiration, just sudden pain on the right upper quadrant, and they keep the respiration. So another one, right upper quadrant pain also. B, systemic signs of inflammation, for example, fever, elevated CRP, or elevated WBC counts, more than 10,000. And the C, also imaging findings, such as the dilatation of the gallbladder, more than 11 centimeter long diameter, and the 5 centimeter in diameter in the short diameter, and the thickness of the wall, and the just probe sign, we say, when you just touch on the right upper quadrant, the ultrasound probe, then the patient will have a pain. So suspected diagnosis is one item in A and plus one item in B, or definite diagnosis, one item in A and one item B plus C. So right after diagnosing, we have to measure the severity assessment criteria for acute cholangitis. Grade 3 means very severe cholangitis. That means is defined as acute cholangitis that is associated with the sudden onset of dysfunction, at least in any one of the following organ or systems, such as cardiovascular dysfunction. That means hypotension requiring dopamine 5 microgram per kilogram per minute, or any doses of norepinephrine. Neurologic dysfunction means disturbance of consciousness. Respiratory dysfunctions means oxygen saturation rate less than 300. Renal dysfunction means oliguria or serum creatinine levels is higher than 2 milligram per deciliter. Hepatic dysfunction, prothrombin time or ion error is higher than 1.5. Hematologic dysfunction means platelet number should be less than 100,000 per millimeter cube, and high fever higher than 39 degrees centigrade. Age, this is changeable. Some literature said 50 years old, or some other literature 75 years old. Hyperbilirubinemia means total bilirubin levels is higher than 5 milligram per deciliter. Hypoalbuminemia means less than 0.7 gram per liter. Grade 2 acute cholangitis is associated with any of two following conditions: abnormal white blood cells higher than 12,000 or less than 4,000, higher fever higher than 39 degrees, older than 75 years, hyperbilirubinemia 5 milligram per deciliter higher than 5 milligram, hypoalbuminemia 0.7 gram per liter. If the patient is not grade 3 and 2, then we categorize the patient grade 1. For the acute cholecystitis, also we can measure the severity of grading. So in this case also, grade 3 acute cholecystitis associated with dysfunction of any one of the following organ systems: cardiovascular, neurological, respiratory, renal dysfunction, or hepatic dysfunction, hematologic dysfunction. Grade 2 acute cholecystitis associated with any of the following conditions: elevated white blood cells higher than 18,000 per millimeter cube, palpable tender mass on the right upper quadrant because of enlargement of the gallbladder, and duration of the complaining at least higher than 72 hours, and marked local inflammation, such as gangrenous cholecystitis, pericholecystic abscess or hepatic abscess, or biliary peritonitis, or emphysematous cholecystitis. Grade 1 mild acute cholecystitis does not meet the criteria of grade 3 and grade 2 acute cholecystitis. Grade 1 can also be defined as acute cholecystitis in a healthy patient with no organ dysfunction and the mild inflammatory changes in the gallbladder, making cholecystectomy a safe and low-risk operative procedure. There are several factors predicting a poor prognosis in patients with acute cholangitis. Two different authors mentioned that acute renal failure, old age, older than 50 or 75, female sex, pre-existing cirrhosis, presence of liver abscess, malignant biliary obstruction, concomitant medical problems such as cardiovascular diseases or respiratory diseases, less than 7.4 about the pH, and higher bilirubinemia, 90 microgram per mole per liter, and less albuminemia, 30 gram per liter, and platelet counts less than 150,000. So when we diagnose severe or moderate acute cholangitis, as soon as possible, of course, we have to begin the treatment. We have to give broad-spectrum antibiotics, such as cephalosporin or ciprofloxacin or metronidazole. And then, according to patient's condition, we can decide which drainage should be preferred. So there are at least 3 ways for biliary drainage. Endoscopic way, so this is endoscopic nasobiliary drainage or endoscopic biliary stenting. Sometimes if we failed to do endoscopic examinations, then in those patients we have to perform EUS-guided biliary drainage, or sometimes surgical disturbed organ such as a gastrectomy or something like this. Then in those patients, we have to use double balloon or monoballoon enteroscopy guided drainage. If we cannot succeed those ways, then in those patients, we have to try percutaneous drainage ways, such as percutaneous transhepatic biliary drainage, percutaneous cholecystostomic drainage, or percutaneous cholecystostomic aspiration. But aspiration, generally, we don't prefer because of complications. And finally, if we cannot succeed endoscopic or percutaneous way, in those patients, we have to choose the surgical drainage. So when should we perform biliary drainage? Drainage should be reserved for patients with cholangitis and septicemia, severe symptomatic jaundice, especially intense pruritus, delayed surgery, before neoadjuvant chemotherapy in jaundiced patients. When we look at the literature, I have to mention that if there is no acute cholangitis, generally we should not perform any drainage because according to literature, there are several literatures comparing in those kind of obstructed jaundice patients. Biliary drainage may shorten the life of the patients and much more complicated the patients. So what is the most preferable biliary drainage for acute cholangitis? Surgical way or endoscopic transpapillary way or EUS guided way or percutaneous transhepatic biliary drainage. So endoscopic nasobiliary drainage or stenting, comparative study, there are many. You see here plastic stent on the left side and the self-expandable metallic stents on the right side. biliary drainage by nasobiliary drain and drainage by stent are equally safe and effective treatments for patients with moderate and severe cholangitis. As you see here, several articles just comparing these two conditions. And also the safe and the effective treatments, both methods, in acute cholecystitis. There is one comparative study about endoscopic nasobiliary drainage versus endoscopic stenting for acute cholangitis. So in this study, nasobiliary drainage 162, biliary stenting 156 patients compared each other. And when we look at the forest plot analysis, technical success rate, clinical success rate, adverse events rate, and also reintervention rate almost similar each other, and there was no statistical difference. US-guided versus ERCP-guided biliary drainage for obstructed distal malignant stricture. This is another systemic review and a meta-analysis. Again, EUS 112, ERCP 110 patients included. Again, in this study, forest plot analysis shows us technical success and clinical success almost the same each other, and also procedure duration in minutes almost the same in two methods. And again, adverse events, stent patency, similar each other. However, stent dysfunction requiring intervention is much more in the ERCP cases. Another comparative study is ERCP biliary drainage or EUS biliary drainage, the preferred decompression modality for malignant distal biliary obstruction. This is a kind of meta-analysis and of randomized clinical trials, included 220 patients. When we look at the results, also overall adverse events, biliary peritonitis, rate of bile duct infection, and stent reintervention almost same in these two methods. However, after ERCP, pancreatitis is much more in ERCP cases. Another multi-center randomized clinical trial comparing EUS-guided biliary drainage versus ERCP for the primary palliation of malignant biliary obstruction. In those patients, when we look at the procedure time, almost the same. Almost EUS less than ERCP. When we look at the adverse events, early events, especially less than 2 weeks, again, EUS less compared to ERCP. Late complications also less in US compared to ERCP. Procedure-related pancreatitis less in US compared to ERCP, and mild or moderate or severe complications, again, less in US patients. Reintervention rate, again, less in US patients. Sorry. So this case, maybe you will see seldomly, hydatid disease located in the liver and ruptured into the biliary duct, and the patient had a severe cholangitis, fever, leukostosis, and the enlargement of the bile ducts. And we had to do ERCP and the sphincterotomy, and just we take off germinative membrane from the common bile duct. And of course, after that, the patient subsides easily. This patient also very severe acute cholangitis cases. As you see here, there is a huge diverticulum and the papilla inside of the diverticulum. The patient had a common bile duct stance and the fever and the enlargement of the common bile ducts and biliary hysterotomy, and we just take off, sorry. You see sometimes pus coming. Yeah, after removing the stents, the patient subsides easily. So there are pros and cons for endoscopic stenting. Pros: absence of discomfort and no loss of electrolytes or fluid. Cons: it cannot be known in real time whether the stent is patent or occluded. There is a risk of dislodgement or clogging of the stent. When a stent with a diameter larger than 7 French is inserted, then EST is necessary. For endoscopic nasobiliary drainage, pros: no additional EST is required. Clogging in the tube can be washed out and easily removed. And then bile cultures can be done, and drainage and the bile can be monitored anytime. Cons: patient's discomfort from the transnasal tube placement. Sometimes, especially elderly patients, self-extraction and the dislocation of the tube are likely to occur, especially in the elderly patients, and loss of electrolytes and the fluid, as well as collapse of the tubes by twisting, may also occur. About the outcomes of the balloon enteroscopy-assisted ERCP, there are several published articles, as you see here, very less adverse events. So if the anatomy disturbed by the surgeons, then in those patients we can do balloon enteroscopy-assisted ERCP. There's a comparison of outcomes between EUSBD and the PTBD as an alternative drainage procedure. So when we look at two articles, there was a comparative randomized clinical trials. And in those trials, EUSBD has less advanced adverse events compared to PTBD. So we have to remember that EST had many complications, especially for the beginner. So when we look at these complications, pancreatitis 1.9 to 5%, hemorrhage 2 to 3%, cholangitis 1 to 1.7%, cholecystitis, perforation, and mortality 1.3% can be occurred. So we don't have to perform EST in every patient. If, especially elderly patients, more pure, the patient has more pus in the liver, then small stones, then in these patients, we don't have to do EST. We can just large balloon dilatation for the papilla, and then nasobiliary drainage can be successfully performed. Okay, indications of percutaneous transhepatic cholecystectomy also can be trial. So gallbladder access more than 95%, but biliary tract access less than 5%, much more difficult because it's difficult to just pass through the cystic duct. Of course, there are complications of this method. Percutaneous cholecystoma, also sepsis, hemorrhage, and death. There are complications. Nasobiliary gallbladder drainage versus nasobiliary gallbladder stent, also similar effect and the side effects. Okay. So the time is important for biliary drainage. If you are late, then organ dysfunction will be higher than before. I mean, 24 hours, much more successful. Okay, surgical or radiologic or endoscopic way, comparing each other, then as you see here, surgical complications and mortality rate at least 2 times of endoscopy. The same in this study also. So the last slide, Mr. Chairman. Grade 1 acute cholangitis patients, we have to use antibiotic. If the patient subsides, then we don't have to do more. And then we can treat the real etiology. But if the patient cannot subside, then in this patient we have to do biliary drainage. In grade 2, we have to do early biliary drainage. If we are late, then mortality rate will increase. Plus antibiotic, plus general supportive care, if the patients need it. Grade 3, urgent biliary drainage, plus organ support, plus antibiotic. We have to treat, and then after subsiding, then the etiology should be treated. Mr. Chairman, ladies and gentlemen, as a conclusion, biliary drainage should be performed for acute cholangitis regardless of the degree of severity. Endoscopic transpapillary biliary drainage for acute cholangitis should be the first-line drainage route. If ERCP-BD is failed for the patients with acute cholangitis and surgically altered anatomy, balloon enteroscopy-assisted ERCP or EUS-assisted BD should be recommended. Endoscopic nasobiliary drainage or biliary stenting should be preferred in patients with acute cholangitis who have coagulopathy or who have receiving antithrombotic agents without EST. If endoscopic or percutaneous way is failed for biliary drainage, then surgical treatment should be performed for the palliation, and as soon as possible, the surgeon should finish the operation. Thank you very much for your kindness to listen to me.
Thank you, Professor Ormechi. At this point in time, I request all 3 distinguished speakers to join us here. So we're going to open the floor for the question and answer. So I'd like to throw the first question to Professor Corniawan. So how do we monitor if the hepatic abscess is well treated? Do we request imaging to tell us that the abscess is totally drained?
Okay, thank you for the questions. So first we need to see imaging is I think is very important, but also the clinical findings also, like maybe if the abscess is less than 3 cms, we can see there's an improvement with the antibiotics. If we can see the fever subsides, there's no fever for 3 days. Yeah, 3 days we give the antibiotic, there's a fever subsides, no fever with no antibiotics. I think it's very good improvement. Even to see the reducing size of the abscess is not as fast as the clinical signs that we can find. That maybe we can see in weeks. We can also do the repeat ultrasound to see the reducing of the size if this the abscess is less than 3 cms. Maybe the larger abscess, we can see the reducing, we can expect the reducing size only by giving antibiotics. So in a few days, we also, beside the improvement of the signs or clinical symptoms, we also expect the reading size in 3 days, 3 or 5 days. We can see the reading size if we do the aspirations or the catheter drainage.
Thank you. So, and, any questions from the audience? There's available microphones if you have any questions.
One question for Dr. Saud Nawaban. Is there any new development of vaccine for the dengue and malaria as well? I think that prevent the disease, I think, is more important.
Yes, I think for the vaccine, yeah, we have vaccines. Also for the leptospira, also we have vaccines, but in Indonesia we don't have both vaccines. And I think from the data we can see that by giving vaccine we can decrease the incidence of cases per year. And I think in endemic regions like in Asia Pacific, like in Asia Pacific region, I think prevention is also very important for the vaccines. Yeah.
Any question? One question for Professor Ormechi. When you decided to do the percutaneous drainage, bile drainage, to the gallbladder or to common bile duct?
If we cannot succeed the endoscopic way, I mean, if we failed, then in those patients we have to try to percutaneous way. This is one indication. Another one, if we know that pus, so a lot of pus in the biliary duct, then in those patients we prefer percutaneous biliary way because we have to wash out the biliary duct by the nasobiliary stenting or percutaneous stenting. Then in these two conditions we prefer the percutaneous way.
Because sometimes we have a difficulty to puncture the gallbladder, right? Sometimes the gallbladder have a small space, yes? Small space from the liver.
For the gallbladder, of course, there must be indication for acute cholecystitis. If there is a cholecystitis, then, and of course, if the contraindication for the surgery, then we cannot operate the patients. And then in those patients, of course, we do cholecystostomy by direct tube. And then just take off the pus from that tube and the patient feel comfortable.
Are there any questions from the floor? Okay. So at this time, I'd like to thank my co-chair, Professor Pidadi, our three distinguished speakers, Professor South Horace Nababan, Professor Jafferdi Cornyawan, and Professor Nekati Ormechi for sharing their expertise with us. And also I'd like to thank everyone for attending this session. So I'm now closing this session. Thank you very much.
с этой стороны снимать, потому что с той стороны я... Aduh, suruh sekolah. Anjir tampil emang. Dia manggil Kak Wahyu bro. Iya, oh iya. Oh emang asyik ke. Tapi kayaknya soalnya Kak Wahyu kan nemenin dia terus kan di Mengwi jadi ini, jadi chairman-nya dia gitu. Diurusin terus deh. Emang kayaknya orangnya asik kue deh. Iya emang sih. Asik kue deh. Bener-bener asik kue. Aduh. Coba cari yang kayak gitu dong. Ada nggak sih? Tapi yang muda gitu gimana sih? Carinya di Gresik kan kemarin kan? Iya nggak sih? Kan berita Greswa nggak ada yang deket lah. Kayak old gitu malah lebih muda, maksudnya lebih cetar Greswongnya lebih cetar ini gitu nggak? Siapa kayak siapa yang kemarin Vincent siapa? Vincent yang pergi banget? Vincent masih lebih look mudanya si dosennya mas? Seumuran deh. Iya kan nggak yang kayak gitu yang gitu? Ada. Tapi yang asik, yang pintar, dan kayak gitu udah nggak ada. Masa sih? Kok kata cerita temanku sedikit ya? Oh iya, aku sampai. Aku tadi dari tadi ada kali untuk 3 orang ngaji motor aku, tapi kayak udah tua gitu. Aku males ya. Kayak iya tadi nggak iya kayak iya udah punya pacar bilang mau nggak sama anak saya anjir gila kan ya terus kayak iya ada orang Indonesia dari Surabaya 1, ada yang dari Turki, tapi ya ini nggak ada yang muda gitu apa ya. Justru di sini tuh pengennya
Dear colleagues, our session will begin now, and I want to introduce my co-chairman, Leander Siregar, from Jakarta, and let's begin. Please, Professor.
I'm the speaker. Yeah.
And the first speaker is our chairman, Leander Siregar, with hepatopulmonary syndrome updated on pathogenesis and clinical pictures. Please, Professor.
Thanks, Chairman. Ladies and gentlemen, I want to talk about hepatopulmonary syndromes, update on pathogenesis and clinical features. We know that there is hepatopulmonary is one of complication of the cirrhotic patient. If there is some patient with cirrhotic with pulmonary hypertension, so it could be some hyperdynamic circulatory syndromes admit one of syndrome, it is hepatopulmonary syndrome, beside another symptom, clinical syndrome and others like hepatopulmonary syndrome, hepatic encephalopathy, and others. Patient with cirrhosis and portal hypertension that can develop complications from a variety of organ system leading to multiple organ failure. But we have hepatopulmonary syndrome is characterized as triad. One is liver disease, and the second one is intrapulmonary vascular dilatation, and the third it is arterial hypoxemia. It is the prevalence of hepatopulmonary syndromes because you know that not only the patient with hepatopulmonary syndrome could be have this syndrome, but another kind of disease have be preference for hepatopulmonary syndrome. It is adult patient with end-stage liver disease. The percent it is 4 until 30%. Children, cirrhotic patient, it is quietly 15%, but it's wide from 10 to the 23rd percentage. And in chronic viral hepatitis with or without cirrhosis, the prevalence is 10%. And in Buchiari syndrome, it is prehepatic portal hypertension, it is 28%. I think it is very hard to treat hepatopulmonary syndrome. So the best treatment it is liver transplantation, and it is the impact of liver transplantation. You have that after the transplantation, hepatopulmonary syndrome who did not undergo transplantation, 5 years survival at 20%, and median survival it is 24 months. How to make the diagnostic criteria for hepatopulmonary syndrome? One, it is the patient have liver disease and the presence of liver disease and or portal hypertension. And the second one, it is they have some defect oxygenation. It is partial pressure of oxygen less than 80 mercury, or arterial oxygen gradients more than 15 and or more than 20 for patient with more than 65 years old. And the third it is we have defect in pulmonary vascular dilatation. It is positive finding when we have contrast enhanced echocardiography or abnormal uptake in brain more than 6% with reactive lung perfusion scanning. It is the arterial PO2 gradient. It is normal value 5 until 8 millimeter mercury, and it increases with age. X is years divided 4 plus 4. It is the contrast echocardiogram. It is before the administration of agitated saline contrast, and it is the presence of echogenic microbubble immediately after injection or agitated saline, and it is fully echogenic microbubbles in left atrium and ventricle tricardiac cycles. It is for diagnostic of HPS. On the other hand, we have a technetium level macroaggregated albumin MEA scanning to detect quantity and intrafemoral something in hepatomegaly syndromes. It is the left side it is normal and the right side it is abnormal of MME scans. It is the origin for the diagnosis of hepatomegaly syndromes. If we have a patient with chronic liver disease, with or without portal hypertension with dyspnea, firstly we check pulse oximetry. When pulse oximetry saturated more than 96% more than, so no severe gas exchange abnormality or moderate to severe is unlikely. So repeat saturation during patient evaluation every 3 months. If the patient saturation is less than 96%, so we can do a contrast enhanced echocardiography or MAA technetium scan. And then if negative findings, no hepatomegaly syndromes, that it is positive because there is the bubble is immediately in the atrium and ventricle, or the abnormal brain uptake more than 6% of technetium level in the brain. So I think it is positive for hepatomegaly syndrome. And then it checks the arterial blood gas analysis. And if we have arterial gradient less than 15 millimeter mercury, it is no hepatomegaly syndrome. Even they have severely intravascular vasodilatations. And if we have arterial alveolar gradient more than 15 and arterial pressure more than 18 millimeter mercury, we have mild hepatomegaly syndromes, and we can follow up every 3 months. And the patient with arterial pressure more than 15 milligram mercury and the partial pressure arterial more than less than 80, we can examine it with chest computer tomography, pulmonary angiography, pulmonary function test.